want, we can start. So we can, or you want to be in the same organization as it's prepared?
No, I'm supposed to be the first one to start, I think, right?
Yeah.
Yes.
And I have a long presentation, 150 slides.
Yes, you can make it within 7 minutes and a half, no problem.
7.5?
Yeah, because you tell me you need only 6 minutes, so I give you 1.5 minutes more.
It's everybody yesterday took 10 minutes and we have extra time at the end. So we are not going to leave you any extra time today.
Today, yes. Okay, go. Good. Let me start. Assalamu alaikum. Good evening, dear colleagues and friends. We'd like to start the second medical retina session in 8 quick conference. Today, I'm really happy that we are having a very eminent speaker in this session. As usual, you know, all of them, they are eminent and they are very experienced in their field. So I have Professor Dr. Majdi Musa, my dearest friend, and I have my dearest Professor Prasan Rao, Dr. Ahmed Rushdi, also he is joining in a few minutes, and Dr. Fahad Kuhel. So today we will talk about wide field imaging, so multimodal imaging and wide field imaging in the management in vitreoretinal disorders. We will start with Dr. Majdi Musa, and he will give a talk about wide field retinal imaging in real life practice. So Dr. Majdi, the floor for you, please.
The floor is mine. Thank you, Dr. Mohammed, for the kind invitation. Thank you for the fruits you showed us. We didn't taste it, but we will taste it at the end. I think you can see my my presentation now. Can you see it?
Yes, please.
Shall I start?
Please.
Okay, let's start. Thank you again for the kind invitation. I'm glad to be there and with new colleagues today. My introduction, or the first lecture, is about ultra-wide field imaging in real life practice. So there is a consensus on the classification and guidelines of wide field imaging, which was published in Ophthalmology Retina 2020, because there was a lot of debate. What is the meaning of wide field? How many degrees? What's the wide field OCT, wide field OCT angiography, wide field fluorescein angiography? So they gathered together and they put like a consensus. What is wide field in 2019? So this is the consensus definitions. As we can see in the picture, the posterior pole is the retina within the arcades, which it used to be all the fluorescein angiography machines getting. Then the mid-periphery, which is the region of the retina up to the posterior edge of the vortex ampulla, as we can see here in the wide field ICG. Far periphery region of retina anterior to the vortex vein ampulla, and wide field single capture, which is not mosaic, centered on the fovea, capturing the retina in all 4 quadrants, posterior and including the vortex vein ampulla. Ultra wide field is a single capture view of the retina, far periphery in 4 quadrants, as we can see here. This is the ultra wide field, and pan retinal is a 360 degree. No machine up till now can get a 360 degree. Only contact lens can get you 360 degree, which is the pan laser photocoagulation lens. So wide field in real life practice and ultra wide field, we speak about color fundus, fluorescein angiography, OCT, fundus autofluorescence, ICG, and OCTA. We used to have 15 degree color fundus and fluorescein at the beginning, that's at the late 70s, and then came the 35 degree, and the standard cameras is the 50 degrees. Till the last 2 decades, we have only this, and we used to do this. But sometimes it is not quite good enough, because most of the lesions, when you see this, it's in the extreme periphery, and we need that in one field. And then came the wide field spectralis and the wide field optus. Spectralis could cover up to 102 degrees, as you see the picture on the left side, and this is the optus up to 160 degrees, which is an ultra wide field, and it's beyond the ampulla of, as we can see, of the vortex vein. How about evolution in OCT? We used to have a 6 millimeter at the beginning, then we get 9 millimeter, and then we get 12 millimeter in one line scan, which can show us what is going on in the center and in the paramacular area. As we can see here, vitreous splitting into 3 layers. If we don't have that long line scan, you will never be able to see these changes, especially if you are going to surgery. And nowadays, the maximum you can get is a 16 millimeter line scan, which can be done with many machines nowadays in the market. How about the evolution in the OCTA? They started by 3 by 3 by 3 millimeter cube, and then 9 by 9, and then 12 by 12, which is the maximum any machine can get. Not speaking about the mosaic, but speaking about single picture. The ultra wide field imaging, there was contact and non-contact lenses, and like the red cam, it's a contact. The Optus is a non-contact. Spectralis, they have contact and non-contact. This is the red cam imaging we can see in children, where we can get a peripheral lesions like this, and you have to take many quadrants to make mosaic. About the Spectralis has two types of wide field, ultra wide field lens, which you have to use a contact. This will get in contact with the cornea. It's very annoying, and I don't think it's used anymore after the Optus. And this is the non-contact, where you can get 102 degree. So this is a wide field, this is the central, this is a wide field, and this is an ultra wide field, which you can get by the Optus. Spectralis versus Optus, as we can see, the Spectralis, the maximum you can get is 102 degree. The Optus is up to 160 degree in one capture. And as we can say, the Optus is not a real color. It's a two laser source, which can get similar to true color, but it's not a true color. And it has different wavelengths and autofluorescence and plus ICG. And this is what we can see by the Optus, 160 degree, and then you can magnify the picture you want. And this is another wide view with the Optus California, the new machine in the market a couple of years ago, where you can get up to the ampulla and beyond that. And this is a wide field ICG, which is very important nowadays in studying the pachychoroid. Is it really important in real life practice? And which system we can use? I showed you most of the system, but this is the 7 ETDRS standard field. And we can see we were missing a lot of things if we go beyond this, like neovascularization and proliferative diabetic retinopathy. And I think Dr. Raoul will cover that. But let me give you two real life examples. This is a patient who was diagnosed as non-proliferative diabetic retinopathy with the standard view. But if you go peripheral, you will find neovascularization. So you can change even the degree of diabetic retinopathy from non-proliferative to proliferative if you go further peripheral. Also, mild non-proliferative to severe non-proliferative if you examine the periphery. And if you count on this, you will miss these lesions. Also, following the treatment, why the patient every now and then is getting vitreous hemorrhage like this picture, because it is not quite good enough PRP, missing a lot of ischemic areas at the retinal periphery and mid-periphery. And this is what we need PRP sometimes if you have repeated vitreous hemorrhage. Florid NVE and NVE, you need to examine the periphery before diagnosis. And again, targeted retinal photocoagulation, if you target the periphery, you examine the center, it's free, but if you target the periphery, the center will keep dry. Again, sometimes during the retrovalvular injection, you can get a penetration, and it's easy to get that with a one color fundus picture. Real life practice giant tear is very important to examine and to document by Optus. Again, dropped IOL with retinal detachment. It's very fine and very documented to see that preoperatively. Again, acute retinal necrosis, the extent in the periphery, you can see that at the periphery, and it's only one picture which will help in the diagnosis and the follow-up of these patients. Angioma at the periphery, you can see the feeding vessels and the draining vessels. ROP, which Ahmed Rojdi will speak about in a few minutes, how you can examine, diagnose, and treat PRP by documenting preoperatively patients with ROP and then do the retinal photocoagulation. Juxtafoveal telangiectasia, we always look at the center, but most of the lesion here is at the periphery. The ischemia, the light bulb configuration of dilatation of the capillaries, the extensive ischemia is mainly at the periphery. And again, we have to look at the periphery in RVO, in uveitis, where the periphery is very important, where the source of leak in this Harada disease and the multifocal choroiditis. Long-standing retinal detachment with demarcation line, you need to examine the periphery to know the extent of this retinal detachment and how the retina is severely ischemic in this long-standing retinal detachment. And even if it is self-limited, you need to laser at the periphery, so you will forget about this for a long time. In wide field OCTA, as I speak, in the proliferative diabetic retinopathy, this is a 12 millimeter. You can see 12 millimeter cube, you can see the NVEs. But if you combine both of them, I think this is quite good enough to see the center and the periphery. Start treating the patient, combining OCTA with structure OCT. And this is the Zeiss Flex Elite, which is a very good machine. It's not in Egypt yet, but it's a very good machine, giving you a mosaic of 12 by 12, and you can get up to 16 millimeters. Also in retinal vein occlusion, this is a hemi vein, one of my patients, and I did OCTA. I looked at it and compared it to the fluorescein. It's very comparable, where you can find where is the NVEs. And after the intravitreal injection and laser photocoagulation, you can see the regression of the NVEs. Still, the ischemia is there, but it's already treated by laser photocoagulation. There is a limitation. Once you get a very wide field, you see the artifacts at the periphery because the retina is concave. And whatever the periphery you reach with fluorescein, it is not comparable to OCTA. OCTA is still limited in the periphery. And we all know that montage will not solve the problem, especially if you do multiple 12 by 12. You will find out that this retinal periphery will never be able to be seen in focus. Also, long line scan, 12 by 12 millimeter, you can see the traction in the center and nasal to the disc. So you will never forget about this. And once you diagnose traction and macular edema, there is another traction nasal to the disc. Long line scan, which can give you the staphyloma. Look at the 16 millimeter line scan, where the peripapillary staphyloma can be clearly delineated, and we can see and study this staphyloma to detect if they have any breaks around the staphyloma. In color and fluorescein, in diabetic retinopathy, fundus autofluorescence is very helpful, so you will never augment the PRP without doing fundus autofluorescence, so you will not hurt the retina anymore, and you can pick up where the the laser is not done, and you can fill in the spaces. This is one of my cases where the retinal attachment in the right eye came with metamorphopsia in the left eye. And look at the huge, two large tears. The patient is only 6/6, but he's complaining of metamorphopsia and photopsia, and floaters. And I found two large breaks, and I did laser photocoagulation. And during the follow-up, only one shot to see if I already sealed this break or not. Also, fundus autofluorescence in macular dystrophy or retinal dystrophies, you can see how much the affection of the RPE. This is one of the funny cases who's complaining of, floaters every now and then after intravitreal injection. And look at this. This is the silicone bubble we can see after repeated intravitreal injection, and it can be documented by one shot. Again, you can use a very wide field color, very wide field by montaging the OCT, by montaging multiple 12 by 12 millimeter scans, so you can get up to the mid periphery, and you can combine this with OCT angiography, and I think this can replace fluorescein angiography nowadays. So my take-home message: through retinal examination, including slit lamp, thorough retinal examination, including slit lamp and indirect ophthalmoscopy, is still the standard of care of all patients. So if you are efficient enough to examine the patient with a non-contact lens or even a contact lens, it can overcome any kind of investigation, but it needs a very good skill, and it's objective. It depends on the subject, but using ultra-wide field imaging is very helpful in the diagnosis, documentation, and monitoring of this patient. Thank you so much for your listening.
Thank you very much, Dr. Majdi, for this an excellent presentation and comprehensive as usual and direct to the point. Really impressive. So we can move to the next talk. It will be by Dr. Prasan Rao, and he will give a talk about role of wide field imaging in diabetic retinopathy. Prasan?
Am I audible and my slides are seen?
Yes, we can see it clear.
Good evening, everyone. Thank you, Dr. Amri, for giving me this opportunity. I'll be speaking on the role of ultra-wide field imaging in diabetic retinopathy. So it's basically a little continuation of what Dr. Majdi just said. So we have to be very clear about the nomenclature here. As Dr. Majdi mentioned, ultra-wide field imaging is a single capture showing retinal features anterior to the cortex venia ampulla in all four quadrants. So as seen over here, this is ultra-wide field. And pan-retinal is an image displaying the aura to aura for 360 degrees. It is obtained through montaging of the optos images. So this is how we understand what is ultra-wide field and pan-retinal imaging. So what are the various machines we have in the market? We have the optos, which has a maximum view of 200 degrees, Mirante, which is 163 degrees, and the Clarius, which is 133 degrees. And each of them have their own advantages and disadvantages. So let's start with what is the role of ultra-wide field imaging in diabetic retinopathy. So the first and important thing is screening and diagnosing diabetic retinopathy. So when you do ultraviolet field imaging, it improves the detection of diabetic retinopathy lesions and leads to more precise diabetic retinopathy grading. This has been shown by various authors, and it also detects higher retinopathy levels in approximately 10 to 15% of the cases what we see. So this is an image of a wide field angiogram where the patient, if you look at the posterior pole, has most of the lesions, but in the periphery you have this peripheral vascular leakage noted over here. Next, if you look at another few things, ultra-wide field angiogram detects greater number of neovascularization and capillary non-perfusions. So this is a patient where if you look at the central, if you take two images in the center, the majority of the angiograms are neovascularization is in the peripheral temporal quadrant of this patient. Also, ultra-wide field color images show improved detection of rates of peripheral neovascularization. So how is this important? Because if you miss these lesions in the periphery, you might not, you might fail to treat these patients, and eventually they'll end up with vitreous hemorrhage and the other sequel of proliferative diabetic retinopathy. So these are some of the black and white images where you can clearly see the presence of neovascularization in the periphery, in the superior and the inferior nasal quadrant. Next, how do we monitor diabetic retinopathy? So we know initially we looked at the 7 ETDRS fields in the which are basically localized over the disc, macula, and around in the around surrounding areas. But Silva et al. Described predominant lesions were in the peripheral visual fields. So we coined a term for this as predominantly peripheral lesions, or PPL. And these have been defined as microaneurysms, hemorrhages, venous bleeding, IRMA, NVE, in eyes where 50% of these graded lesions were outside the standard 7-field images. So this is where you can see in this patient, the predominant images are in the peripheral part. So what is the significance of this? They looked at eyes and they showed that eyes with PPL had a 3.2-fold increased risk of a 2 or more step DR progression and a 4.7 increased risk of progression to PDR compared to eyes without PPL. So if you see patients with peripheral lesions, just keep a watch because they have a higher incidence of progression, both in terms of the number of steps of diabetic retinopathy and progression to proliferative diabetic retinopathy. Also, ultra-wide field imaging can predict the risk of post-vitrectomy bleeding. So post-vitrectomy bleeding is a big challenge in eyes which are treated with vitrectomy. They often have multiple bleedings, and you want to find out these causes. So you can see these patients have more peripheral predominant lesions as seen on the angiograms. What about DME and peripheral ischemia? Now, this was a big debate or a topic which was discussed about a decade ago. We know that the peripheral retina largely, if it's ischemic, produces a large amount of VEGF. But is there any correlation of this peripheral ischemia and DME? So certain authors looked at peripheral ischemia and they tried to compare it with the rates of macular edema. And they found that eyes with retinal ischemia had about 3.75 times higher risk of rates of macular edema as compared to those without retinal ischemia. And a strong correlation between peripheral vascular leakage and focal macular edema were also seen in eyes without peripheral non-perfusion. However, some authors had a contrary view. They said that there's a moderate correlation between the foveal avascular zone areas and peripheral ischemic index, and between the peripheral leakage index and the foveal avascular zone. Some of them even said there's probably no association between non-perfusion, the ischemic index, and the clinically significant diabetic macular edema. So the jury is out here. We really don't know what plays a role here. But if you look at the images here, this was an article published in British Journal of Ophthalmology where they measured the amount of peripheral ischemia and they tabulated it, and they clearly demonstrated that diabetic macular edema and retinal ischemia are significantly related to each other. And from this route turned out the next thing, So if you say that the peripheral ischemia is the driving force for diabetic macular edema, does targeted retinal laser photocoagulation help? So what is targeted laser photocoagulation? It's a selective application of laser only to the areas of non-perfusion, which is detected by the FA. And the principle behind that is to reduce the VEGF produced and also to minimize the side effects of the laser. So this was a study which was published in Acta Ophthalmology and even in British Journal of Ophthalmology, where at 12 weeks they found that the PDR regression occurred in 76% of the eyes. The complete disease regression occurred at 37 weeks. At 37% of these eyes at 24 weeks. And there was a significant reduction in the central retinal thickness as measured on OCT over a period of time. So this is another clinical trial where they compared three types of laser treatments: the targeted retinal photocoagulation with a standard pan-retinal photocoagulation, and something where they called as minimally traumatic PRP, where the burns were not visible. And when they did this, they found that despite similar rates of PDR regression in all the three groups, a significant reduction in central retinal thickness was found with targeted retinal photocoagulation and minimally traumatic PRP. So this is important because now we can actually look at lesions when you're doing the angiogram and see which are the areas which are ischemic and target those, rather than doing those large burns which used to get in the past, which always compromises patients' vision in the periphery and also the contrast. Finally, what is the role of telemedicine in diabetic retinopathy? Now we have these excellent cameras which take wonderful images of the retina, and ultra-wide field imaging has found to be utility in telemedicine programs for diabetic screening because of the speed of acquisition, patient comfort, because most of these cameras are non-mediatic. The acquisition time is very fast. You don't need to dilate these patients. So telemedicine in conjunction with ultra-wide field device increase the coverage of screening, increase the referral base, improve the clinical compliance of screening. However, it is associated mild increase in visits here. What is the use of ultra-wide field OCT imaging to differentiate between severe and NPDR and DR patients? Now here they looked at OCT to differentiate between IRMA and NVE. Why is this important? Because we know eyes with severe NPDR, if you have IRMA, then you generally we may or may not treat, but eyes with PDR you generally want to treat, and it's important to differentiate between the two. So one of the ways for doing that is an invasive fluorescein angiogram, where you inject a dye, and this can be associated with various complications. So some of the authors looked at this, and they defined IRMA as characterized by hyperreflectivity lesions in the inner retina, stage 1, and outpouching of the ILM as stage 2. And they characterized NVE as disruption of the ILM, which is stage 1, horizontal growth along the posterior hyaloid, stage 2, and multiple breaches of the posterior hyaloid and linear growth as stage 3. So these are some of the images which are published in the article. This is an unmagnified view highlighting the area which was captured here, and this is a magnified view. And here the OCT scans clearly through the area of suspicious IRMA clearly demonstrates this hyperreflective lesion which is breaking through the ILM. Similar images in the other eye. So when you examine this patient, you probably think this patient has severe non-proliferative diabetic retinopathy. But however, you scan a certain area of this large IRMA, you can clearly see the presence of NVE, which is detected on the OCT. Another patient here with very few features on the retina. However, if you look in the peripheral part, you can see this NVE. So it is sometimes confusing for us because we generally look at the hemorrhages and changes on the venous side. However, you might find up a very innocuously looking lesion in the periphery, which might actually be a NVE. Finally, what is the use of a wide field OCT imaging here in OCTA imaging in diabetic retinopathy? So the authors actually looked at alteration of retinal microvasculature in eyes with preclinical diabetic retinopathy using the ultra-wide field swept source Octa image. So here you can see peripheral areas where there are changes in the peripheral part where the patient didn't have any lesions on the color photograph. You can see areas of capillary non-perfusion in the lower inferior quadrant and in the upper nasal quadrant in this eye. They showed clearly that peripheral areas presented significantly more microvascular dilatation tortuosity than the central areas, and there were more non-perfusion areas than center with borderline significance. And the important thing to remember is the number of lesions were associated with HbA1c levels. So higher the HbA1c level, more the changes in the peripheral part. And this is again important because we again just look at the colored images and say what is the staging, but however, there might be underlying changes happening in the microvascular level, which goes undetected. Again, a wide field OCTA image in a patient with diabetic retinopathy, where you can see this is the OCT image. You can see the V-scan with the overline flow values here. And this is the wide field image on the fundus angiogram, where you can see there's a sort of a correlation, almost a good correlation, when you do the ultra-wide field OCTA in PDR patients. What about AI in ultra-wide field imaging in diabetic retinopathy? Now, optos retinal imaging and its ability to capture the peripheral lesions has been clinically validated. And recently, this was an abstract from RO where Optos AI for DR demonstrated excellent disease detection performance with a sensitivity of over 96% and a specificity of over 93%. So AI can now be used to diagnose and look at these cases. So finally, what is the take-home message here? Early assessment of diabetic retinopathy using ultra-wide field imaging is very important for managing our patients' visual health. Ultra-wide field retinal imaging captures the peripheral lesions, and this has been clinically validated, and it facilitates early detection, management, effective treatment of diabetic retinopathy, and finally, it seems to be irreversible for early diagnosis and management of retinal diseases. So thank you very much for your patient hearing.
Thank you very much, Dr. Prasan, for this excellent presentation, as usual. We can move to the next, then we can have the discussion at the end. We will have now Dr. Ahmed Rushdi, and he will give a talk about wide field imaging in ROB. مساء الخير يا باشا.
مساء الخير. Good evening.
Good evening to you.
Thank you very much, Dr. Muhammad, Dr. Magdi, for the opportunity to participate in this prestigious meeting. Give me just a second to share my screen. Can you see my screen now?
Yes, please.
Okay, so my talk will be about ultra-wide field imaging of retinopathy of prematurity. We know that ROB is a leading cause of childhood blindness worldwide, and early and accurate diagnosis is significant for early treatment and good prognosis. We know that the binocular indirect ophthalmoscopy has been the standard technique for screening ROB in premature infants, but has many limitations because this technique is subjective and needs qualified ophthalmologists, and images are not stored for future reference. But what about digital imaging in ROB? Digital imaging using wide-angle digital retinal photography has been an alternative method for screening ROB. RetCam has a high reliability and accuracy for detection and follow-up of ROB, but however, it has many limitations. So the RetCam limitations are there are many limitations because it requires a position to the cornea, so it's contraindicated in infection and early postoperative period. And because the camera's weight can decrease the perceived severity of stage and of the disease and the blast disease. And there have been reports of retinal hemorrhage during RetCam examination due to the weight of the camera. And it captures only 130 degrees of the fundus. What about ultra-wide field imaging? We know that the ultra-wide field imaging can capture 200 degrees image of the retina, and it is non-mydriatic. However, for easier capturing in premature babies, I usually dilate the pupil. And of course, it's non-contact, and this is a huge advantage of ultra-wide field imaging. So how can I capture images using Optos in those infants? First, the infant is wrapped for more comfort during capturing and for prevention of hypothermia. And I use topical anesthesia. Then I use eyelid speculum to open the eye. And I usually place a few drops of lubricant to prevent corneal dryness due to opening of the eye by the speculum. So in this photo, you see low quality of the image and artifacts from the corneal dryness. Just after applying a lubricant, you can see how we can capture a high resolution image without any artifacts. And then one assistant holds the infant, and a second assistant holds the infant's head to keep the head stationary during the capture. Then when the light on the screen turns green, the photographer presses the shutter button. But sometimes due to excess mobility of the head or movement of the head, sometimes we cannot capture on the green color. So if I can capture on the blue color, that's good. I can still get a good images by capturing on the blue color. So ultra-wide field imaging can accurately detect and diagnose stages and zones of the ROB. Like in this photo, we can see here stage 0, which is immature blood vessels without any ROB. And here is a stage 1, which is demarcation line that divides the vascular retina from the avascular retina. Then as the disease progresses, we go to stage 2, which is a ridge. The ridge has height and width and develop from the demarcation line as the disease progresses. Sometimes you have a ridge with excess vascular branching close to it, but as we see in this case, here there is a blood vessel crossing the ridge. If you see a blood vessel that start to cross the ridge, this indicates a regressing disease. This is a good sign. As the disease progresses more, we go to stage 3, which is extraretinal fibrovascular proliferation. We see here new vascularization extending from the ridge into the vitreous, like also in this photo. And here we can see also new vessels, and we can see clearly the ridge and the vascular branching adjacent to that ridge. If the disease is not properly treated, we go to stage 4. Here in this photo, we see a stage 4A, which is partial retinal detachment, not involving the macula. When the macula get involved, we get stage 4B. If we have total retinal detachment, we get stage 5. As the severity of the ROB increases over time, the retinal blood vessels develop dilatation and tortuosity, giving the blast disease. Here we see in this image the blast disease. There is dilatation and tortuosity of the blood vessels. Also, ultrawide field imaging allows us to accurately follow up the progression of the disease. So here we see a shunt vessels and the flat ridge at zone 2. And after 1 week, there is progression to stage 3. Here we can see that the flat ridge developed multiple new vascularization. But still, we don't have a blast disease in this case. This is the other eye of the same patient. Here we have a demarcation line with mild peripheral vascular branching and tortuosity. And after 1 week, there is progression also to stage 3. We can clearly see new vascularization. Here is another patient that progressed from stage 2 to stage 3. Here we can see a stage 2 in zone 2 with no blast. But after 1 month, the ridge evolved into a new vascularization, indicating the progression of the disease. Here we can see new vessels that developed over the ridge. But then vascular growth happened or occurred distal to the ridge. So the ridge developed a new vascularization, indicating a progression. Then the vascular growth happened at more peripheral location, meaning that we had a regressing disease at some point, but then the disease progressed again, leading to formation of a new ridge at a more peripheral location to the old one. So in ROB, we can have regression and the progression of the disease, multiple attacks of progression and regression of the disease. There is a special entity of retinopathy prematurity, which is called aggressive retinopathy of prematurity. It's a rapidly progressive severe form of ROB. Its clinical features are characteristic and different from the classical ROB. And if not treated at the proper time, this disease usually progresses to stage 5 ROB. And it is usually seen extremely premature and low birth weight infants, and those associated with bad general conditions like sepsis, pulmonary disease, and necrotizing enterocolitis. As we see here, this is a case of aggressive retinopathy prematurity. It's usually a posterior location. We have a prominent blast disease with tortuous retinal arteries and dilated retinal veins at the posterior pool. But the hallmark of that disease or this entity is that blast disease is out of proportion to the peripheral pathology or the peripheral retinopathy. So we don't see here the ridge and the extra retinal new vascularization we see in the classical ROB. But what we see here is shunt vessels and large vascular loops as the junction between the vascular and the avascular retina. This is very important because we don't develop here a ridge and we don't develop here an extra retinal fibrovascular proliferation. So we see a blast disease out of proportion to the peripheral pathology. We see shunt vessels, we see vascular loops, and here we see also the vascular loops and the multiple shunts between the vascular and the vascular retina. And there is also a very important characteristic of this disease is that we see a large avascular area within the vascularized retina. So if you see here, there is large at the site of these arrows, we see a large avascular areas inside the vascularized retina. And we see a flat network of new vascularization early in the disease, and as I said before, without a pre-existing ridge. So it is usually a flat network of new vascularization without ridge. Sometimes we in aggressive ROB, we can have hypoplastic major arcades and hypoplastic macular vessels. So as we see here in this case, the arrow is pointing to the fovea, but as we see here, there is a very poor development of the macular arcade. So the arcades are just developed just beyond the very little distance beyond the fovea, but most of the macular arcade are not formed. Here's the other eye of the same patient. We have also a hypoplastic major arcade and hypoplastic macular vessels. As I said, this disease, if not properly treated at the proper time, it usually rapidly progresses to retinal detachment. This baby was examined by another retina specialist and diagnosed as aggressive ROB. The case was referred to me, but the parents came after 3 days. Just after 3 days, we started to have a retinal detachment here peripherally. So now we have a stage 4A just in 3 days. Also, ultraviolet field imaging helps in follow-up of ROB patient after treatment. In this case of aggressive retinopathy prematurity, I gave an intravitreal injection, and after 1 month, we can see the regression of the blood disease, and we can see the disappearance of the hemorrhage, but we can see that there is still vascular loops, as these arrows are pointing to the vascular loops. But after I followed this patient for another month, after 2 months of the injection, we can see that all the vascular loops have disappeared, and the blood vessels started to go to a more peripheral location. But as we see here, we still have a large avascular area. I'm still following up this baby to see if this large avascular area will vascularize or not. This is the other eye of the same patient. 1 month after treatment, also we have still some vascular loops persistent. But after another 1 month, after 2 months from the injection, we can see that all the vascular loops have disappeared. Case 2 is also an aggressive retinopathy prematurity. After injection, we can see disappearance of the blood disease, disappearance of the vascular loops, and just a very minimal loops remaining. But after 5 months from the injection, we can see that the retina is completely vascularized. The other eye of the same patient with aggressive.
We are behind the time. If you can.
Okay. This is, all these are the same cases of aggressive ROB. Just is the last one. This is follow-up after laser treatment. This infant had injection 2 times and then had in recurrence after the second injection. I lasered the retina, and now we can see the good laser treatment with no skip areas. Ultraviolet field imaging can help to make sure that you don't have skip areas of laser. And finally, we can assess the persistent avascular retina after injection. Here we have this infant at 65 weeks post-menstrual age. We have a large persistent avascular retina. Here we have also a persistent avascular retina. In this case, we have a very small persistent avascular retina, less than 1 disc diameter. So take-home message that ultraviolet field imaging capture a 200 degrees image of the retina. It's non-mediatic, it's non-contact, allows accurate diagnosis and follow-up of the ROB, but has many limitations. May be difficult to capture images if the infant is very irritable with excessive head mobility, and it's difficult to capture images as the infant gets older, and it cannot be safely done if the examination requires general anesthesia, and there is artifacts from the lashes and the speculum. Thank you very much.
Thank you very much, Dr. Ahmed, for this an excellent illustration about using a ultra-wide field imaging in retinopathy of prematurity. Maybe we'll come back to you at the end of the presentation for discussions. Okay, so we can move now with the last presentation by Dr. Fahad Kuhail. He will talk about the role of wide field imaging in uveitis. Dr. Fahad.
Hi, Mohammed. Can you, first of all, thanks for the kind invitation. Can you hear me clearly?
Yes. Yeah, we can hear you. Can you share your?
Of course. So again, thanks ever so much, Mohammed, for kindly inviting me to participate in this symposium. So I was very interested in both the 2 previous talks, particularly Prasan's. It's fascinating to see that wide field may become more, quite quantitative and not just qualitative. much like we use OCT. So there seems to be a lot of research invested in using how to use wide field imaging diabetic retinopathy to better make treatment decisions. In uveitis, I think it's still at the qualitative stage, and we're still kind of finding our feet, and the research isn't as well developed as, say, in diabetic retinopathy. But when I trained as a fellow, all we had was a color fundus photograph that had a 30-degree field of view. So this is a patient with serpiginous choroiditis. He's got fingers in the right eye. Yes, you can delineate some of the chororetinal changes affecting the macula. But in the olden days, when you had the old camera, if you wanted to get outside of the macula, you had to do what we call a 7-field photograph, where the disc and macula would be photographed, the posterior pole would be photographed, and then you'd get the patient to look up and left, down and left, up and right, down and right, to get those supranasal and infertemporal quadrants. And then using clever software, you'd stitch this together in order to make a montage. And as far as 2013, this was a patient of mine with diabetes, and you take this kind of sequence of images. And then, like I say, the software was clever enough to stitch it all together to make a montage, but still you're getting a very limited field of view. You're talking 50, 55 degrees possibly. But, and you've seen it in all the talks today, Optos wide field in one image, you're getting vast swathes of retina at one time, and just really helps in identifying pathology, identifying features that sometimes you might even miss on slit lamp biomicroscopy. So, it's really made a difference to my own practice. So this is the same patient. So this is the serpiginous chorioretinal atrophy. I look at how much more information you get from one particular capture. So, for example, although my biomicroscopy is going to be good, I'm going to identify all of these changes. Do you really think my drawings will be as accurate and as precise in order to monitor this disease over time? And sometimes with some of these uveitis patients with very low-grade retinopathy, so they've not got aggressive vitritis, aggressive cells, pain, sometimes it might just be chororetinal lesions. How am I going to detect that my immunosuppression over time is keeping the disease under control? Well, it's simple: OCT, autofluorescence, but also wide field photography, because then I can compare the same patient, the same eye over 12 months. And if I see the same distribution of chororetinal lesions, then I'm confident that I'm keeping the disease under control. So really it has made a difference in the treatment decision making, as well as the diagnosis. So in my own practice, I use the Optos, I use the autofluorescence, I do wide field FA, wide field ICG. With the Heidelberg, I tend to image with the 55 degree or 105 degree and use wide field infrared reflectance as well as FI ICG. And I kind of use all of that together to kind of make treatment decisions about the patients, either in terms of diagnosis, but also monitoring the patient over time, particularly if it's a cold uveitis. So the patient hasn't got pain, the changes are very, very slow over time. How do you know what you're doing is enough to keep the disease under control? Imaging is the way forwards. And we'll very quickly skip over this, but essentially, you're getting this wide field image because you're looking at the light reflection along an ellipsoid mirror that's then reflected on the back of that eye. And then these are the lenses that I would use on the Heidelberg. So this is the 55 degree that allows you to do wide field infrared reflectance, autofluorescence, but also you can capture wide field OCT. Not quite as good as the Optos wide field that Prasanth showed us, but still gets really good quality images. And then this is the 105 degree to allow you to do a wide field fluorescein angiography and ICG. So this is a patient who came with toxoplasmosis. She had significant sudden loss of vision, first ever episode. She had this area of retinitis supratemporally. You've got widespread periphlebitis. And so I treated her with orosteroid, azithromycin. This is her left eye. And again, if you pick up, you can see these subtle choroidal changes in the nasal fundus of the left eye. This is the autofluorescence that you get with the Optos. So that's probably a leopard spotting or bear track change in the left eye. And then this is the wide field OCT. As I said to you, taking the 55-degree, and there's a cut through the active lesion. You've got an elevated hyperreflective lesion with choroidal shadowing, with vitreous cells in the pre-retinal space. This is very typical of toxoplasmosis, and there's a really good paper by Dr. Agarwal from Cleveland in the Survey of Ophthalmology, where he really describes some of the OCT findings in various forms of retinitis. And urge you all to read that very, very useful article. But this was her eye afterwards, about a month afterwards. And as you can see, the retinitis is getting better, the view is improving. You can now see some of the RPE scarring, which kind of helps you confirm that you're dealing with toxoplasmosis. And these changes here are just artifact, dirt that's within the lens. And obviously her periphlebitis is improving. And then this is the wide field autofluorescence. Again, you're seeing a regression in that area of retinitis with some hypofluorescence on the autofluorescence, confirming that we're dealing with an RPE or chororetinal lesion. This is another patient who came in with Behçet. So he comes to casualty back in Sheffield, where I used to work in the United Kingdom, with sudden loss of vision in the right eye. He had hypopion. He had previous history of penile ulcers and erythema nodosum. He had a macular infarct in his right eye, but as far as I was concerned, the left eye looked to be normal. There was no AC inflammation. The vitreous was clear. Disc was healthy. Macula was healthy with normal retinal vessels. And obviously, as you know, with Behçet's, we like to see bilaterality to be confident that we're dealing with Behçet's, because otherwise you see retinitis like this, you need to be thinking about acute retinal necrosis or a viral retinitis. In this case, I was more relaxed because of the other constellation of symptoms that made me feel this is Behçet's. But as always, you want to kind of see that bilaterality to reassure you that you are treating the right thing and you are along the right lines. So this was his fundus fluorescein on the spectralis, again 55-degree. So you get a bit more of a view than the disc and macula. And as you can see, he's got widespread leakage in that right eye with hypofluorescence due to the retinal ischemia. But the key thing is the left eye. So again, if you look at the 55-degree, the left eye looked to be what we call normal. But on the Optos, you can see disc leakage and peripheral leakage that I could not identify clinically. So without wide field fluorescein angiography, I would have missed this subclinical peripheral retinal vascular leakage. Really helpful in cementing that this was the right thing, and we could escalate him straight away onto anti-TNFs. And he was started immediately on intravenous methylprednisolone. He did well. This is another case of a patient with just on color fundus photography. So although I've examined him, the view is sometimes very hard. I'm suspecting he's got sarcoidosis because he has chronic cough, shortness of breath. His chest X-ray shows bihilar lymphadenopathy. But again, I'm trying to identify all the periphlebitis lesions. So I've spotted some of them, but you can take an Optos and you identify even more, and you've got something to compare to over time. And then this is his fellow right eye. And again, fluorescein really helpful in identifying these kind of peripheral vascular changes. And the wide field fluorescein was helpful in this case because although you could identify periphlebitis on the fundus photography, on clinical examination, it wasn't a particularly exciting fluorescein, no significant retinal ischemia. So I decided to treat this patient with topical steroids only and not institute systemic immunosuppression. So here, wide field fluorescein angiography had a real bearing on my treatment decision making. So does wide field influence management? So this is really good paper from Dan Doe and Kwan from the United States, where they studied the impact wide field retinal imaging has on management in non-infectious uveitis. And just if you look at the highlighted section, management was altered in 16% of patients based on examination and limited FFA, whereas in 48% of patients had a management change with the use of ultra-wide imaging and angiography. So clearly, ultra-wide field allows you to detect this greater disease activity and really helps you as a uveitis consultant to escalate the treatment decision-making should you need added evidence to be more aggressive. And like I say, if it's a hot uveitis, it's easy because the patient will be in pain, the vision will be blurred. It's when it's cold uveitis when the problem. Mohammed, do I need to stop? Do I need to stop?
Yeah, please. If you
No
are
problem.
okay.
No problem. Thank you.
Thank you very much, Dr. Fahad, for this excellent presentation and in the form. Okay, so let us just have a few questions. We have Dr. Majdi, Dr. Ahmad, Dr. Prasan, and Dr. Fahad. They cover most of the use of wide field in diagnosis and their effect also in our treatment. Is there any question to Dr. Majdi? He give us an overview about the role of the wide field in diagnosis and management, effect management in different things in related to retina and either age-related or whatsoever the disease he mentions. Any questions, Dr. Majdi? Prasan, because you are the one who was with us.
Dr. Majdi, I want to ask you the role of peripheral OCT in retinoschisis. Do you use it regularly, and how do you use the peripheral OCT? Because I find it a very interesting tool. Because in the past, one of the ways to monitor these patients with peripheral retinoschisis was to do sometimes a visual field, because we know that retinoschisis usually causes an absolute scotoma, and if you want to see a progression, one of the ways was to do visual fields in this patient. But you have some patients who are very small, young patients like 11, 12-year-old who have these schisis in the periphery. So do you regularly do OCTs, peripheral OCT for these patients?
Thank you for the question. It's not all the patients, because again, sometimes the young age is not that cooperative. But you know, I use the swept source, so sometimes I like a sweep the periphery by radial line scans, 12 millimeters, just taking multiple line scans through the periphery to examine if the schisis, how it's extending, how much elevation of the retina, if I can detect any inner or outer holes. But still, it's a bit difficult. It can be done, but it needs full dilatation because you need the periphery. It needs a rapid screening. You cannot do the cube because the cube is not that high definition. So I use the radial 12 millimeter for the periphery, 2 radial line scans, 12 millimeters, so I can detect. And as your question, I have just a case yesterday with a retinoschisis, and I need to see the progression in the periphery. And he was 26 years old, so he's very cooperative. And I see the macula and I see the periphery. So it's another way to monitor these patients and to see what is going on, especially if the patient develops new symptoms sometimes.
Yep. Yes, Fahad, please go ahead.
I mean, it's really good, Professor Magdi, that you do have an ultra wide field kind of OCT. I mean, do you really feel it's made a big shift in your practice or your diagnostic ability? And do you think people should just swap their current Optos for this, or wait till they need to upgrade their Optos so their Optos breaks down and they're looking for a new one? Or should we just get rid of our current ones and buy this because it's a game-changing development?
I don't think we can afford doing that in Egypt. We don't afford these things in Egypt anymore. So again, whatever you have, keep it and use your talent to do that. But you see, the Optos is, I think it's one of the best up till now. And I've seen a late presentation by Dr. Paulo Stanga where there's a navigation, OCT navigation on top of ultra wide field in the California Optos. So they can, just demarcate where the area you want after taking the color. You just put the demarcation.
Dr. Majdi, we lost him, or are you still hearing him? Prasan?
No, we are not hearing him. I think we lost him.
Dr. Majdi, we have some issue of connection. Okay, I want to ask you, Prasan or Fahad or Dr. Ahmed, can you use a wide field imaging in just to without examining the patient? So if you are in a busy and they give you the photos, so you can make a decision on that, because sometimes even you can see better than when you are examining by yourself sometimes. What do you think about that in practice? I mean, yes, Fahad, please.
So in the UK, we were doing it all the time because there was one doctor for a lot of patients. There was absolutely no way I could physically see them all. So what we used to do, we used to take an Optos or a Claris with an OCT, vision pressure, and then myself and a team of optometrists who are kind of very trained in assessing diabetic retinopathy would use that to make decision making regarding anti-VEGF, laser. And, you know, we were very successful with really good outcomes, and very few patients kind of came to casualty because we'd missed some neovascularization or missed some diabetic macular edema. I don't particularly do it in the UAE because I'm working in a private setting, and so the patients want to see me. But definitely, if I was in a government hospital and my burden of treatment was greater than my ability to deliver, then I would definitely use these imaging in order to assess patients. I think it's just as good. And then from time to time, you would catch up the patient for that human face-to-face interaction.
Okay,
And I was doing it for the last decade in the UK.
Okay, Prasan, please. Yeah, Prasan, because we have no time. Can we go fast, please? Yeah.
Yeah, Dr. Amri, just to say that we are all trained with indirect and scleral depression. So that's our bread and butter sort of. But the only indication where I really feel Optos plays a role is pediatric retina cases. Because these pediatric retina cases, invariably, they are very uncooperative. Even if you have a full dilatation, you sometimes miss findings. So I think one way to look at the retinas of pediatric patients to do an Optos, and then you can get a very wide field image and also very magnified image. So you can try and pick up subtle changes happening in the pediatric retina. So that's why I find it very practical to use Optos.
Just one comment. I want to take this one from Dr. Ahmed. You know that sometimes you don't want to dilate. You know, some patient, they come to you and he is following with you, and you want just to, yes, he want immediately to go, and he don't want to be dilated. So whenever you do this one wide field imaging, it can, I mean, take a lot of burden from you and make you can be, I mean, satisfied that you have seen. Is there any medical legal about this one, or you can go ahead and make a decision on that, Ahmed?
Yes, absolutely. So for pediatric retinal disease, almost I use it routinely in every visit for ROB patients. But in adults, I see a huge advantage for non-dilating subunit. So let's say if I have a patient with BVD, I want to examine him every 2 or 3 weeks. I don't want to dilate him every 2 or 3 weeks. So if he comes to me every 2 or 3 weeks, I will just do an Optos. I will not dilate the patient. So I think this is a huge advantage that we can examine the entire retina without dilatation, as you said.
Okay, I mean, for follow-up with diabetic patient having diabetic retinopathy, or he is not having any diabetic retinopathy, can you depend, okay, to take a decisions about that?
Yes, absolutely. I can take decisions only on depending on Optos. Yes.
Okay. I think we don't have a time because we move little. The time is move very fast. But the presentation was superb, and it was very nice and excellent. We need a lot of time to discuss, especially your cases, Dr. Ahmad and Prasan and Fahad and Dr. Majdi. But unfortunately, we are behind the time, and I think Dr. Muhammad Awadallah, he is steering to me by his eyes looking. He wants to take over. So we want to conclude our retina, and we can pass the mic and floor for Dr. Muhammad Awadallah for surgical retina in this hall. Thank you very much, Prasan, Fahad, and Ahmad and Majdi, and see you inshallah in the future. Bye-bye.
Thank you. Thank you, everyone. Thanks a lot.
Here with Awadallah, no problem. You can join us also. It's a great honor if you want to have.
Thank you. Thank you. Thank you.
Thank you, Dr. Muhammad.